the definition of sepsis, the latest definition, we can include that in the operational management of patients. So patients, you come across patients with suspected infection, then you look at quick SOFA, and if the quick SOFA is more than or equal to 2, the SOFA score, and you assess the function of organ, you look for evidence of organ dysfunction. And if the SOFA score is more than or equal to 2, call it sepsis. And if the patient is in shock with mean arterial pressure less than 65 and serum lactates more than 2 millimeters of 2 millimoles per liter, we call it sepsis. And if the SOFA score is less, you monitor the patient clinically and reevaluate the patient, as the possibility of sepsis cannot be ruled out by a single examination of the patient. If the patient is Q-SOFA is less than 2 and he's still suspected, again, we need to monitor the patient continuously. Depending on the organ failures and the SOFA scores, you might decide to put the patient on a ward or on a monitored bed, like in ICU or high dependency unit. So the sequential organ failure assessment score, as you can see, or this is in short, it is called SOFA score. And you can see that each we are testing about 5 or 6 systems are included in these parameters. A score of 0 to 4 is given for various parameters in each system. And respiratory system, we look at PaO to FiO2 ratio. That is, for doing this, we have to get a blood gas done. If a blood gas is not available, we can look at the ratio of SpO2 to FiO2, right? And better the patient is, we give lesser score. That is, for a normal patient, he gets 0 in each parameter. And in cardiovascular system, you look at mean arterial pressure and the dependence of patient on the inotropes or pressors, as you can see on the screen. And in liver, you look at the bilirubin, less than 1.2 gets 0, 1.2 to 1.9 milligrams per deciliter, it gives 1, and 2 to 5.9, 2, 6 to till 12, it is 3, and more than 12, it is 4. And renal, we take creatinine in milligrams per deciliter or millimoles. In coagulation, we take the platelet counts into account, and that is graded again with 0 to 4. A neurological parameter, that is Glasgow Coma score, is assessed and a score is given. And based on this, we assess the organ systems involved and the severity of sepsis. And as you can see, the SOFA score is not easy to be done in every patient, because it involves a lot of lab parameters, and that would take some time, and the facilities to do all these tests may not be available in every healthcare setting, leave alone the corporates or the bigger cities having these parameters. But in villages and smaller towns, all these parameters may not be able to be tested. So a quick SOFA scoring system is designed, and this involves 3 parameters which are easy to assess, and we get some idea about the severity of disease or which direction your patient is going. Can you wait on him, or you have to be you have to keep him under monitoring? So that this would involve the systolic blood pressure, which is less than 100 millimeters of mercury, respiratory rate more than 22 per minute, or altered mentation, that is confusion, lethargy, agitation, coma, etc. And each of these parameters are given scores, and that is used in assessing the patient's severity of disease. And when you're dealing with sepsis, we have to see if there is an infection. And if there is an infection, where is the infection? And if there is an infection somewhere, what exactly is causing the infection? So sometimes we might not be able to know the site of infection, but we might be able to assess that or assume that there is an infection. And we might also be able to isolate the causative agent, but we might not be able to get the site of infection. In other combination, we assume that we see that there is an infection with direct or indirect markers, and the site of infection is also seen uh, with clinical examination or history and the imaging techniques, but we might end up not being able to isolate the causative agent. So in these combination of situations, we need to work and treat the infection, and with target of getting the patient better and save his life. So to know if there is an infection or not, obviously there is history and examination. We need to the history and examination carries major importance in suspecting an infection in a particular patient. And the other biomarkers would also help, like the biomarkers like C-reactive protein, procalcitonin, interleukin-6. So these are in addition to multiple n number of biomarkers we can test, these are supposed to be sensitive and specific biomarkers, and almost all three of them are available in most of the clinical care settings. And thanks to COVID, the interleukin-6 is also made available in many hospitals. So these three biomarkers help us to confirm that there is an infection. And it is said that the elevated biomarkers, though it would indicate an infection, it won't guide you in initiating the treatment therapy, antibiotic therapy, but that would help in deciding the duration of antibiotic therapy. And the trends in biomarker concentration would guide you through when to stop, or any modification required, etc., etc. So confirming the site of infection, as I said, initially you may not be clear about the site of infection because the patient comes to you with signs of infection and signs of sepsis, but it might be somewhere deep inside the body, or you may not get any information so that you can point your finger at a particular part of the body. And later on, with clinical examination, you might be able to. If with clinical examination you're not able to, you might have to take the help of imaging to localize the infection. So knowing the site of infection would guide us in selection of empirical antibiotic therapy. If it is in brain, you would go for a different set of antibiotics. If it is in the lung, it is different. If it is urine, that is different. And if it is in the peritoneal cavity, obviously you would choose a different set of antibiotics. So the site of infection is very important in choosing your empirical antibiotic therapy. In addition, if you have a site known, you can decide whether it needs surgical clearance or instrumental clearance of the infection. And also, is this, if you know the site of infection and if you have seen some collection there, and over serial examination or imaging, you would be able to see the success of antimicrobial therapy. So for this, history and physical examination is very, very important. The imaging techniques, imaging studies, and if possible and if required, you may go for contrast studies also. And if you're going for contrast studies, obviously you would look at the kidney function and see if you can go for contrast study or not, so that you weigh the risk and benefit of doing some contrast study and then go ahead. And as I said, it might still remain unclear till the end, and the patient may get better and go home. But the answer to your question, where is this infection, you may not get it after all the hard work you have done. And again, so we have looked at two parameters. Is there an infection? And where is the infection? And now, what is it that is causing the infection? So that is important, again, because the antibiotic therapy, if you know and you're giving targeted therapy, you might expect a better response after knowing a causative agent and its sensitivity patterns. So whenever we come across a patient, you take microbiological culture samples before you embark on the antimicrobials. And we collect at least 2 sets of blood cultures and other specimens from suspected site of infection. And unfortunately, the cultures to grow the organisms would take longer time than we can actually give to start treating the patient. So we take the culture samples and specimens and start empirical antibiotic therapy to cover the most appropriate cover with most appropriate antibiotic, or we go for wider and broader and stronger antibiotic initially, depending on the patient's condition and the possible suspected infection. And unfortunately, the positive blood cultures are found in only 30%, and in some studies, say up to 60% cultures are positive. But as you can see, up to 40 to 70% of patients, the cultures we may not be able to reach a causative agent, identify a causative agent. And then comes the role of molecular culture-independent identification methods, which are based on PCRs or other serological techniques. And as we can see, the cultures definitely would be more specific and sensitive. And the PCR-based techniques, they can be oversensitive, and we might end up getting flags for more than one organism. One organism may be the causative agent of the sepsis, but the PCR-based investigation may give information about the possible infection with more than one organism, and we might end up treating all of the organisms with various combinations of antibiotics.